Breakaway from Cancer program. And so we appreciate their financial support to allow us to be here in your community and providing this information to you. Just a little bit about the Illinois CancerCare Foundation, and I think each one of you have at your table one of our brochures, but we are a 501c3 non-for-profit organization that exists to support cancer patients and their families in all of the communities that Illinois CancerCare serves. So all 12 clinics throughout Central and Western Illinois. We predominantly support clinical cancer research and encourage patients that are eligible to participate in those trials, and our foundation funding helps to do that. We also support a variety of advocacy programs and educational programs such as this, genetic screening programs for patients, and a number of support programs that are offered throughout the clinic. So that's just a little information about us for those of you that weren't familiar with the work that we do. I'm going to introduce Dr. Bajaj here in a few minutes, but a couple of things that would be really helpful to us. You have kind of a blank 4x6 card at your table. This is intended for you to write down questions that you might have as Doctor is giving her presentation this afternoon. So we will have Lauren and Leslie help collect these if anybody has them, and then we'll take those questions after her talk. And then the other thing that we'd like you to do to help us with future programming is you have an evaluation form. If you would be so kind as to fill that out before you leave today, and that will really help us moving forward as we begin to plan these types of programs for other groups and areas. I know many in this room already know Dr. Bajaj, but I know some of you maybe don't, so I'll give you a little bit of background on her. Of course, she's a medical oncologist, internist, and hematologist with Illinois CancerCare. She joined us in 2012. She did her undergraduate education at the University of Illinois at Champaign-Urbana, and then did her medical school training at Saba University. She completed her internal medicine residency at the University of Missouri at Kansas City, and also her oncology hematology fellowship at Wayne State University in Detroit, Michigan. She is triple boarded, so she's board certified in internal medicine, medical oncology, and hematology. And she's going to talk to us a little bit about prevention. And so I welcome Dr. Bajaj to the podium.
So I was very pleased when Janet had asked if I would talk at this expo, and I had asked, the first question I think I'd asked her was, how come this is the first time we're doing something like this? And this is such a wonderful community outreach event. Oftentimes, I think that the question that I guess asked most in the clinic is, a couple things. Why did I get cancer? How did this happen to me? And is there a cure yet? Okay. The how and the why are they're just natural questions, because you go through life thinking that you're doing all the right things, you're taking care of yourself, or so we think, and then you get the diagnosis of cancer. At any stage in life, I don't think we're prepared for it. Okay. And even after you've experienced cancer, maybe even survived it, every time you hear about it, it still has its aftermath effect on you, doesn't it? And every time you hear about someone who just recently got diagnosed with cancer, even if you've never had it yourself, the anxiety starts. We all feel like we're ticking time bombs, right? So we need to do something as a community, as a nation, as a global effort to try and understand cancer first. How can you fight something if you don't know anything about it? So the first step to preventing cancer is education about cancer. And prevention really is the best cure. It really is the best tool that we have until we can genetically take care of cancer, meaning inject a certain cell into the system that's going to eliminate cancer or remove the cancer cells from our body and get rid of it for good. We are not there yet, so we've got to start the effort with prevention. So, just a quick raise of hands. How many in this room were diagnosed with cancer or know a family member who was diagnosed with cancer or has a friend or family? Anyone? Yeah, pretty much. I don't think there's one person in this room that has not been affected by cancer, either directly or indirectly. And that goes to show that cancer really affects the majority of our nation. So by the end of today, do you know that 5,000 Americans just received a diagnosis of cancer in one day? 5,000 Americans will be notified that they have cancer. Of that cancer is one that grows without a checkpoint, without a stop. And it's one that tends to invade outside of the area that it started, outside of the organ that it originated from, and spread. Usually with the help of blood vessels. And distant metastases, so when we say metastasize, that means that it has lost its balance of geography. So on the left here, the picture is basically showing how benign tumors are different from malignant. The biggest key here is the blood vessels, okay? That is what feeds the tumor so that it keeps growing, and it's also what takes the little cancer cells out away from where they start and spread to different organs. And once they spread, they can do about anything. They truly can. They can hide in areas that they've spread to, making it very difficult to detect them. Do you know it takes billions of cancer cells to come together to form a cluster that's the tip of a ballpoint pen? So by the time we actually see a cancer spot on an image, there's already a lot of cancer underneath the surface. So that's the tip of the iceberg, and that's the battle that we have to face, which is why we don't want to get to that point. Okay? We want to start early, when things are microscopic, or hopefully not even having taken form. So when cancer spreads, another common question I get asked is, well, so if I have breast cancer, and it now is showing up in the brain, is that brain cancer? It's breast cancer that has spread to the brain. It'll keep all its original nature. All the biology is retained. Okay? But it will go to any specific organ and it'll assimilate. It'll know how to use the tissues around them, the blood vessel around them, to keep feeding itself and destroy. So genes in cancer. There are certain things that we cannot change. Okay? Majority of the information that we have in our chromosomes is in DNA. And the DNA, for the most part, is pretty well set when you're born. Okay? That's why it's important to understand that only 5% to 10% of cancers are genetic. So the majority of cancer, up to 90 to 95% of cancer, is being influenced by other things. Okay? And of those other things, it's a host. It's a combination. Radiation, exposure to radiation, what does that do? It damages the DNA. That delicate structure, that helical structure that you see, that pretty much holds the code of our life and how our cells function, radiation can destroy that. Chemicals, including chemotherapy, can cause damage to the DNA. That's how we destroy cancer cells. We disrupt the cancer cell's DNA so that it stops growing and it stops spreading. Viruses can do this. I'll show you soon how there are some viruses that have been linked to changes in the DNA and thus cause cancer. So does cancer happen overnight? Or when did it start? Did this start a month ago? Or did it start 10 years ago? Depends on the kind of cancer. It truly does. Colon cancer has been known to appear 10 years ago and then slowly grow, which is why colonoscopies are extremely important. Because if you do a colonoscopy at age 50, understanding that age 60s and 70s can be the highest incidence of colon cancer, that's usually when most of them are detected in this country, let's start 10 years before. Maybe we'll catch a little polyp before it starts to grow and become cancerous. Whereas lymphomas, they could truly be over a course of a couple months. Leukemias, it can be under a month. So the biology of all these different types of cancers is very unique. But what we need to understand is it's not something that just goes wrong at one time. It's a series of mutations that happen, okay? And that 2-hit, 3-hit, 5-hit theory that we talk about, that's also important because maybe you have done something, chemical-wise, radiation-wise, your diet, your nutrition, to disrupt your genes, to disrupt the balance in your body. Well, it may not be the only, it may not be the only insult. You might have done something else, and then something else. So this slide speaks to me in another way, which is not just the biology, but the fact that what we expose our children to, what our young adults, are exposing themselves to, is not going to manifest itself now. It'll show up later, okay? And this is why we need to be conscientious. So the real key, and probably the biggest effort nationally and internationally, is trying to detect changes in the body early, okay? Hopefully we can detect it at a microscopic level, meaning that I could walk over here, draw your blood, and say, you have 10,000 cancer cells in you. I suggest we start this treatment and get rid of all of them. That would be the goal, okay? Eventually we will get there. I'm confident because if you read cancer literature and research efforts daily, we are getting closer. Like, did you know that for breast, colon, and prostate cancer, we are able to detect microscopic cancer cells in the system? I don't have that technology available commercially yet. Otherwise, I would use it on you, wouldn't I? Right?
Yeah.
Right. So, but we will get there, and I'm hoping that during some part of my career, I'll get to experience that, because we are seeing a lot of progress now that physicians treating cancer 25 years ago did not see. Like breast cancer patients. Now after you have breast cancer surgery, I think a couple of you have seen me and I've given you a score saying you have, a low risk of this coming back. You're good with the pill. You have a high risk of this coming back. You need chemotherapy and the pill. That wasn't there. That wasn't there 5 years ago. So we're making progress. But early detection and prevention is still the key. So how are you going to prevent something if you don't know what the risk factor is? Let's look at risk factors, because those are going to be the key to helping make a difference here. Because at the end of the day, these are the numbers. 5,000 diagnosed every day, 1,500 that'll die from it. Half of the men will be diagnosed with cancer in America, all right? 1 out of every 3 women will be diagnosed with cancer in America. 1 out of every 4 will die from cancer, okay? And those numbers are not acceptable. So a risk factor is anything that's going to increase a person's chance of getting a disease. So some risk factors can be changed, and we've got to work on making those changes, whereas others cannot. Meaning the genes, the DNA that picture I showed you about, some of that stuff is set. So if you have a hereditary form of cancer, that is not something that we can change. But if we detect it early, we can make you live longer. Or we can help your generations down the road make changes so that life is prolonged. So this is an really busy, it looks very complicated. Well, that's because it is true. There's a risk, or risk factors are numerous. There's a couple over here, the ones in red, they're talking about how those are intrinsic to the patient themselves. So age, some cancers are more common as you get older. Prostate cancer in men, okay? Breast cancer in women. Some are more common in females compared to males. Some have to do with treatment, okay? The very treatment that we use for cancer can also cause cancer, again, because it changes your cells, right? And that's why you need to be followed closely, which is why we see you every 6 months, or 4 months, or years, and so forth. And then there's the genetics. And this is a big focus, all right? At Illinois CancerCare, we have our genetics clinic. Dr. Nost, who I know a lot of you know, is the head of our genetics clinic, and he's making really good progress trying to incorporate people. And when I see you in clinic, I think I was just talking to one of my patients right now who I inherited from Dr. Nost, that this is the way we're moving now. Because as a survivor, your efforts are to prevent cancer in your future generations. Then there's environmental and lifestyle. This is very important. This is direct impact on reducing your risk of cancer. So let's look at these risk factors. Let's take some of the most common cancers. Lung cancer, tobacco. So everyone knows this, right? That tobacco is linked to lung cancer. Does that mean that everyone that smokes is going to get lung cancer? No. Everyone that gets lung cancer, did they smoke? Majority of them did, but not all of them, right? However, there are certain kind of lung cancers that are 100% undoubtedly related to tobacco exposure, okay? Meaning, if you have small cell lung cancer, you've had a history of smoking. And you know, it's not just that you smoked. Do you know that the latest research shows that the younger you were when you were exposed to tobacco, those people had the highest risk of cancer? So picking up smoking in your 50s and 60s is not known to be as high of a risk factor as our teens that are smoking, okay? And the highest incidence of tobacco smokers in America are young females, okay? We've got to change this, and as a community, we need to start making efforts to educate our own, educate ourselves and educate our own. Breast cancer, we know that radiation is linked to breast cancer. Genetic changes, so inherited mutations. This is where we're very big on genetic screening. So BRCA1, BRCA2 mutations, the breast cancer genes, okay? If you know that you have a family history of breast cancer, you've got to come in and get screened. Because this is not just you we're talking about. This is generations down the road. Colorectal cancer, diet. So what's the diet? All right, if you have a high fat, animal fat derived, all right, low fiber, okay, a diet that doesn't have any vegetables or fruits, that's strongly related to colon cancer. Excessive cigarette smoking or excessive alcohol use. These are all things that damage the lining of the bowels and make you susceptible. Meaning, let's say you already have some genetic instability, right? Your DNA is, it's kind of, so-so. Remember that 1 hit, 2 hit, 3 hit, all those mutations? Then you add the smoking on top. Then you add the poor diet. You're bound. It's going to happen at one point or another. Prostate cancer, also very strongly related to diet. Changes in the prostate, enlarged prostate. African American race, higher risk of having prostate cancer. Some of it could be testosterone related. There's a lot of theories, and actually there's a lot of solid data. Liver cancer, viruses. This is why it's important, safe sex practices, hepatitis B vaccinations, okay? Those that are in the healthcare industry, making sure that we're all vaccinated. Very direct correlation towards liver cancer. Pancreatic cancer, smoking, diabetes, okay? A diet high in processed sugar and refined flour is linked to pancreatitis. is linked to both pancreatitis and pancreatic cancer. Kidney cancers, tobacco smoking, all right? Or the inherited type of syndrome, that von Hippel-Lindau, gives you a higher risk of kidney cancer. Leukemias, leukemia is a tough one, okay? Because we don't really have a whole lot of diet associations with it, but chemotherapy and radiation, which is why our breast cancer survivors, we need to watch them closely, because if they have changes in their blood work, it's a possibility. Bladder cancer, tobacco, and dyes, all right, aniline dyes. Those are high risk for destroying the very delicate balance of the bladder. Drink your water, all right? I think I've said that at least 12 times today to patients that I saw. Drink your water, cut down the soda, cut down the excessive caffeinated products and the processed high fructose corn syrup. All of those have been directly correlated. Uterine cancers, the tamoxifen that we give has a less than 1 or 2% chance of causing uterine cancer. So hormone replacements, if you are going through menopause and your primary care doctor or someone's talking to you about taking hormones to help cut down those hot flashes, understand that everything that you do to your body can disrupt its balance. And which way that's going to tip, we do not know, but there is data that shows that putting hormones into the system, men that take anabolic steroids, women that take hormones, you can be at a higher risk. So if you choose to, have an educated discussion. Don't just do it because that's what you're being recommended. Ask the questions. Obesity. We've got to work on this epidemic. Okay? And we'll talk about what some of that data shows. Melanoma. Wear your sunscreen. Stay out of direct sunlight. If you had history of a blistering sunburn when you were a child, your risk for melanoma is exponentially higher. I'm saying 10s and 20s and 30 times the risk of the average person, okay? I yell at my nurses for their fake suntans, so they will attest to that. HPV, cervical cancer. See how these viruses directly linked, okay? And we have a vaccine now for HPV virus, right? This is something to strongly consider in our adolescents. Helicobacter pylori, the H. pylori, linked to stomach cancer. Hepatitis B and C viruses, liver cancer. The human T-cell leukemia lymphoma viruses we know are linked to both B-cell and T-cell type of leukemias and lymphomas. HIV, lymphoma, and Kaposi sarcoma. Thankfully, we don't see that as much, but back in the 80s, that used to be a big problem. Epstein-Barr virus, lymphoma. Human herpes virus, sarcomas. So let's look at two of the, probably the most frequently diagnosed cancers. So for female patients, breast cancer. So dietary or direct factors are actually what injures the breast tissue directly? Radiation, all right? Which is why breast cancer patients who've had surgery and then if they're on the pill or if they may get chemotherapy, we now talk about, is radiation also necessary? It's not a blanket statement anymore. And we talk about, is chemotherapy entirely necessary? We are trying to do as little damage as we can, but give the maximum amount of benefit, okay? So now, older than age 70, if you have breast cancer, radiation is not an absolute, okay? And chemotherapy, I would much rather not give as women get older because of this, because you can cause another cancer, all right? This is a discussion you need to have. So what are the other contributing factors? Lack of exercise. Do you know that by exercising at least 20 minutes a day, at least 4 days a week, you can reduce your risk of breast cancer by about 6 times? This is true. National Nurses Health Initiative study showed that number, okay? Excessive alcohol, what does that mean? No more than 1 drink for females, all right, and 2 drinks per meal on a daily basis. Anything more than that is found to be toxic to breast tissue, uterine tissue, and adipose tissue. So deficiencies in vitamin D. If your primary care doc is testing your vitamin D level, it's because it's correlated. Okay? And then insulin-like growth factor. This is where obesity kind of plays into the whole role of causing breast cancer. Early menses and late menopause, no pregnancy or lactation. The less amount of time that the female body spends exposed to estrogen and progesterone, it's probably the least amount of risk we're going to have at that point for developing breast or uterine cancers. Okay? Directly related to hormones. You thought that was complicated. Look at what men have to deal with. Look at all these things that can cause prostate cancer. Okay? Like I said, one out of 2 men are going to be diagnosed with cancer. Prostate is at the top of the list. It's endless. It really is. And this is not all genetic. I think down here they talk about the genes here. This is the genes. Everything else has to do with things that happen to us and are products of our society today. Chemicals we put into our system. Nutrition. Did you know that that they did a prostate cancer study? Tomato sauce, right? Tomatoes themselves were so healthy that they gave a group of prostate cancer patients a non-tomato based diet, and then they gave another group tomato sauce. You know, in your pasta, what have you. The group that ate more tomatoes, which has lycopene, had less, they literally developed less of prostate cancer compared to the group that didn't. So this is a direct study. We're not talking about those that had already prostate cancer. That was a separate study. It already showed benefit there. So prevention lies in nutrition. All right, nutrition really is a big part of this. If you take too much calcium, that's been shown to affect the prostate in a bad way. Too little of selenium, too little of zinc. These are all correlated. You know, we can get you more information on this, but I just wanted to show you the slide so that you understand that it's not just one thing, okay? So, cancer and nutrition. This is a question that we get asked very often. What can I eat? Okay, what can I eat to keep my cancer in check, or what can I eat to prevent cancer? There's a lot of work being done, okay, to help come up with the cancer prevention diet and the cancer control diet, is how I see both of those. And with the cancer prevention diet, we want to focus on high in fiber, okay, vitamins, minerals. It's a good old school type of cooking. You know, when you knew where the meat was coming from, where you grew your own potatoes and your tomatoes, and they weren't laced with insecticides and pesticides and what have you. And it was whole wheat bread and not this white bread that came out of some random factory. All this seems to play a role. So as close to nature you eat, the less likely it seems that we would develop cancer. All right? 5 to 9 servings of fruits and vegetables every single day. If you can't eat it, then drink it in an equivalent. All right? They have those. They have those drinks that you can take. Low in animal-derived fats. So if you must have, meat, lean meat, extremely lean meat. They've done those studies as well. And try and get a lot of your fat from plant-based, if possible, meaning your avocados, your nuts, your olive oil, etc. And try and limit preservatives, okay? So get up and move. What's that about? Physical activity works by both ways. It helps to increase your blood flow so that you get all of those proper nutrients that you might be eating all the good stuff, but if you don't move it around, how is it going to get to all the right places? How are you going to energize the areas of your body that are constantly trying to repair themselves? So you've got to move. Circulation is key. Number 2, it helps to control obesity, which is directly linked to cancer incidence, right? So 30 minutes of activity 5 or more days a week. I tell my patients, if you can get up and move for 10 minutes a day, 4 times a week. Start there, okay? Just walk. That's all you gotta do. It'll pick up on its own. And activity does not have to be like that brisk walking. It can just be stretching, all right? So it's time that we invest in our health. We do the daily physical activity that we need to. Get those Fitbit watches or whatever it is, those things that help you count your steps, and it's all a start. And let's focus on proper nutrition, because it's from us that our families learn and our children learn, and this is our contribution to preventing cancer. So primary prevention, we talked about avoiding exposure to cancer-causing agents, so know your risk factors, okay? And try and modify those: diet, nutrition, exercise, etc. Early detection of cancer. Women should be getting their mammograms. Do not miss your mammograms. And understand, if you have a family history of breast cancer, then you probably ought to be getting screened 10 years before, okay? So know your family history. Let us help you figure out what is the best early detection method for both yourself and your spouse, or a significant other, or family members. And then genetic testing. This is, our foundation can give you more information about that. We do have pamphlets over there. I usually send all of my patients who need genetic counseling or testing down to see Dr. Nost in Peoria. And if we come up with something that is modifiable, right, we can make a difference, then that's great. If there isn't, well, at least it's important, because generations down the road can use that and say, we do have such and such mutation. Unfortunately, there's nothing that can be done yet. Now that changes. That's it. Okay? So live well, eat clean, and ask questions. Invest in yourself.
Anybody got any questions for Doctor? Any questions? This is a bashful group. I find that so hard to believe. You want the questions on the floor? If you want it, yeah. We'll open it up for a few minutes.
Let's face it, you tell us that radiation is a problem, yet if you, like myself, if you've gone and got your mammogram, what are you getting? Radiation.
Yeah, you're right, and that's exactly where we need to, as a community, understand risks and benefits. So when you talk as a cancer doctor, one of our main goals is, what are the risks, and weigh it against the benefits. Okay, so the radiation risk that you would get from a chest X-ray and a mammogram are here, compared to the radiation risks that you would get if you were getting direct radiation type of treatment. The amount of centigrays, grays, etc. is extremely low compared to what you would be getting if you were to get direct radiation beams aimed at treating a cancer. Okay, so the risk that we are taking there is some incremental, low, extremely low dose radiation to the breast by trying to detect a cancer. And remember, that effect isn't over a day or over a year. That can be over a period of time. And they have gone back and done these studies for women who have had mammograms. They were actually the nursing studies. Having had mammograms for 20 years, 30 years consecutively, and looked at their incidence of breast cancer going forward, or other types of cancers, lung cancer. And really the only main thing that they noticed was thyroid. Okay, did you guys come across any of this on the news? That when you go for mammograms, make sure that they are shielding your thyroid gland? So back in the day, before we had the newer advanced, this is probably not something that you have to deal with right now, because the mammogram techniques that are being used currently are not the ones that are associated with this. The older types of mammograms had that risk, all right? It's a work in progress. We are learning every day, but at the end of the day, getting a mammogram has saved more lives than it's taken.
Now, how much radiation is there with digital? I have no idea what.
I mean, essentially none, because it's digital imaging, and the digital imaging, I mean, I shouldn't say none, but not even to the order of our standard mammograms. Okay, the digital imaging, what it's trying to do is it takes a picture of the original breast, and then using the software programs, it tries to compute a replica of what it's seeing, but magnifies it. So the difference between what like a CT scan and an MRI, all right, would be giving you, not that one is necessarily a lot more exposure, it's just using the information that you get in a picture, like pixels. Think about it as pixels and on like a TV screen. So it's just using the information that it has, the data that it has, and then processing it such to give you a clearer picture. That's really what digital is doing more than anything. It's not that it's giving more radiation in order to generate that picture. So I agree. It would be much nicer not to have to go through any kind of testing and still be able to detect cancer.
Well, from my point of view, and I've talked to some ladies here and other meetings I've gone to, I don't need to talk before, but, we've gone for our mammograms all the years,
Yeah.
and they found nothing. And to me, my big concern, because that was what was my issue, was dense breasts.
Mm-hmm.
And that's why, of course, it's too late for me to think about digital or something else, but it seems as though that's where the real problem is. If you don't have dense breasts and you get a mammogram, generally they're finding something. But if you have dense breasts, you're not finding anything until maybe it's too late.
It's tough. And I personally have argued with insurance companies to get patients of mine with dense breast type of presentation, MRIs, okay? And I'll follow them with MRIs. So, and right now, I know that Memorial Sloan Kettering is looking at coming up with an advanced type of ultrasound imaging, all right? So really nothing in terms of radiation type of exposure, right? So advanced ultrasound imaging specifically for dense breast females, okay? Their update on their technology is coming up in September, and I'm going to go to that meeting. But this is, I understand, it's a problem. We're working.
I had mammograms all the time, and my cancer did not show up. It was on the chest wall. And I noticed a lump under my arm.
Right. Which is why the self-exam, being aware of your body, all right? This is what I talk about, invest in yourself, all right? Make yourself the priority. Choose yourself, all right? You've got to be your own advocate. You've got to be able to do your exam, or at least understand what is normal about your breast and what is, so that you know when something's abnormal. And regardless of whether my patients have had mammograms or not, even if they had a mammogram that day or the day before, I will still do a breast exam. Because let's face it, the techs, when you go in, they're just trying to get you in and out, right? They've got their list of patients they need to image. They'll put you into the machine, you'll get the imaging, you'll go out. No one's noticing if your nipple looks a little different, if the skin here looks, a bit off, or if there's a little lump. That is not going to get picked up on imaging. So you've got to be your own advocate and point out things when they're not normal. And regardless of whether you've had a mammogram or not, some of you who have been survivors for more than 10 years and are now following up with a primary care doc or maybe with your gynecologist, if they're your primary care doc, you've got to make sure that your breast exams are happening at least yearly, okay? Regardless of normal mammograms. That's a good point.
Question. It's been 2 years, for me so far. It's so good, but every time I went to get a mammogram, and she would squeeze my breast. A gel-like discharge would come out in her nipple, not on the other one, just the one
The one
that I had
up
surgery. And that was maybe the last 2-3 times. And then the last time, nothing happened like that. You know, no gel-like. And if someone had the size of the nipple that was sitting there, and I looked and I thought, oh my God, what does that mean? And they said nothing. So I was like, is that nothing to be concerned about?
Yeah, and there was no blood in the drain, in the discharge or
I
anything
had
like
no
that.
idea, just that radiologist said it's okay.
Yeah.
So, I mean, when I looked at it, it was like, kind of yellowish.
Yellowish, kind of mucinous type
Yeah,
of, yeah.
greenish, yellowish, but I did see, when I looked down at it, there was no blood in it.
A breast that's had surgery and has had radiation, the architecture of the breast changes. The breast tissue is nothing but fat and lymph ducts, right? So when that gets disrupted after surgery, which it will, okay, there's a lot of inflammation that happens, and it's possible to get mucus type of drainage that comes out. One of the things that you want to make sure is that it's not like mastitis, maybe an inflammation or an infection, and just a basic picture in that. If it keeps happening just on its own, then we could do a separate type of test, which is called a ductal break. You basically just look at the drainage pattern.
It did happen the last time, a bunch of times before that. This last time it was nothing, so I was like, okay. But I was concerned.
And it's good that you pointed it out and you talked to the radiologist. And that's also for, there's always, when you get scans done, there's always a radiologist there, right? And if you have questions about the scan you're getting or the technique or so forth, it's good to ask, all right? This is your body, when things are being done to it, you need to be informed of what the test is, why you're doing it, all right? And if there's any kind of discomfort or something that you've noticed that wasn't brought to your doctor's attention, you can talk to the radiologist. Oftentimes the radiologist will call us. I talk to the radiologist very regularly about things that they notice at the time of the imaging. So they're a point of communication. Glad you pointed that out. Right. What does the report show?
Right, what does the
Meaning, is
report
there
show?
some fibrocystic changes, or is there a cyst, or so forth? Yeah, absolutely.
And so when I called the doctor, the nurses, she told me, sent me a copy.
Yeah.
She says, why can't you read it off to you? She says, I don't think this is for sure, but it says here there's little changes, there's some changes in the search spot. So, she said, there's nothing to worry about. I was concerned.
So that's definitely a question that you need to have with your doctor. Yeah, absolutely. With the surgeon or with your oncologist, with your cancer doctor. Sometimes there's healing that happens and scarring that happens after your breast surgery, and the mammogram is going to pick up all those details. If it looks really abnormal, then they'll do an ultrasound and follow up and biopsy it. So, that's an excellent point, because the mammograms are intended to obviously detect any new disease, but they're also intended to kind of keep an eye on the area of disease that you've had, okay? So if there's changes that are happening there, we don't just have to sit back and watch. I mean, and oftentimes we shouldn't, all right? Sometimes it's indicated, but sometimes you've got to go in, do a biopsy, and just confirm to yourself. Because cancers can happen in actually looking at the image itself.
Yeah, maybe
And-
he saw that, he
Right.
didn't think I knew.
Exactly, so that's usually a discussion between the radiologist and the doc, because the last thing we wanna do is keep subjecting patients to multiple, biopsies and this and that, and chasing stuff around when maybe we would have been just fine watching it at the next mammogram, or doing one sooner, doing one in 6 months instead of a whole year.
I'm concerned about that. So I see my breast surgeon next month, so I can answer her some of those questions.
Exactly. It's a team approach, so we all need to, you do your part, we do our part, the surgeons do their part.
And again, that was is awful lump. There's one big lump here and on the top where the incision is. Well, you could say I'm a YouTube before, so, but I'm going, wow, if there's anything there, I would never know if I feel it.
It is, that is difficult, it's, that's why you need a team. Team approach.
I have a question. I was diagnosed with primary peritoneal cancer with secondary ovarian stage 3. Is peritoneal cancer, does it always accompany ovarian cancer?
Right, so that goes back to that slide that I was talking about, where when cancer starts at one place and it spreads to other sites. So peritoneal cancer is just a description of where the cancer is located. Okay? So ovarian cancer, the biology of those tumor cells, they love to go to the lining of the belly. The peritoneum, think of it as kind of like the onion peel of an onion, that's very thin, flimsy type of material. That's what the peritoneum is. Okay? So those tumor cells love to go and just stick onto it. Some types of colon cancers do that, ovarian can do that. Okay? Other types of gynecologic cancers can do that. So it's really a description of where the ovarian cancer has went.
Okay, so it doesn't necessarily follow one with the other then?
It's a pattern of metastases
Okay,
described with ovarian cancer.
okay.
And if you guys are fans of TED Talks, I don't know if you've watched some of these things, but a really interesting TED Talk that I watched recently talked about how the way that we're describing and approaching cancer as breast cancer or liver cancer, naming where the cancer comes from, maybe going forward, we might be moving away from that. And what we're talking more about is estrogen positive cancer, HER2 positive cancer. All these little molecular tests that we do, that's how we're going to end up focusing on cancer going forward, because we're going to have drugs that target those mutations instead of saying this started in the lung, this started in the liver, etc.
Thank you.
Thank you very much, and Doc and the other staff, they'll stick around for a while to answer any other questions you might have if you'd like to talk to them one-on-one. So feel free to do that. And again, we'll be here until 6 o'clock or until the last person leaves to answer any questions you have. And just as a reminder, if you would just take a few minutes and fill out the evaluation form to help us in planning future programs, that would be greatly appreciated. And before you leave, again, we have a little dessert for you before you leave today. And it's obvious that we didn't check with Doc about the menu today before we had things. So you can all start for healthy eating things tomorrow. So again, thank you for coming. Again, we'll stick around, and thank you so much for joining us this afternoon.